Probably the most common argument you'll hear made against Medicare-For-All is that it's extremely expensive and there's no way we could afford it. Now, if you'll excuse us, it's back to spending trillions of dollars in Afghanistan. People who make this claim will reliably cite the widely publicized Mercatus Center study, which found that over the next decade, Medicare-For-All would cost the government an additional $32.6 trillion. While this is a lot of money, it's actually $2 trillion less than we'd spend under our current healthcare system. We're told by the author of that study that the 32 trillion number is likely an underestimate, given that it was arrived at using assumptions that he calls unrealistically generous. Assumptions about drug pricing, reimbursement rates, and healthcare administration. A close examination of the subject finds that not only are these assumptions justified, but two of them are actually far too conservative. And by my calculations, in just these three areas of healthcare, Medicare-For-All could save over $5 trillion in 10 years. And that's while providing all Americans with comprehensive healthcare. Several other studies arrive at very similar numbers. Proof that these savings are attainable comes from comparing the US against other countries in these areas, and also looking at government healthcare programs within the United States. Surveys of US physicians find that the majority support single-payer healthcare as the best financial reform we could make, and the greatest frustration among physicians internationally is the administrative hassle that comes from having many different payers. Rather than having us pay out of pocket to private insurance companies, Medicare-For-All would fund universal healthcare through our tax dollars. While more money would obviously be spent in taxes to pay for this, private healthcare expenditures would vanish, and the net amount spent per capita would decrease, given the savings that Medicare-For-All provides. Not only that, but the financial burden on poor and middle-class Americans would be further decreased by having taxes that scale with income level and by distributing the taxes among many different areas of the economy. If there's one starting point for this conversation, it's the recent Mercatus Center study written by Charles Blahous. There's been an incredible amount of misinformation and misunderstanding about this study by all parties involved, so we're going to do our best to sort through it all and ascertain the truth. Let's start with how the findings of the study were treated in the media. This Bloomberg headline basically sums up how it was received, understood, and reported, at least at the most superficial levels. Quote, Medicare-For-All would cost $32.6 trillion over 10 years, study says, end quote. In came the naysayers to crap their pants and express their astonishment at what sounds like an astronomically large number. Paul Ryan said, quote, $32.6 trillion. That's how much Washington Democrats' single-payer healthcare proposal would cost over 10 years. It is just absurd, end quote. Dan Crenshaw, responding to Bernie Sanders, said, quote, your plan costs $32 trillion and bankrupts my generation, end quote. Howard Schultz, presidential candidate and CEO of Starbucks, calls it unaffordable. He's like, the only thing that should cost $32 trillion is a Starbucks Frappuccino. Every time I hear this guy talk about politics, it's just non-stop complaining about how terrible Medicare-For-All would be. He's so against single-payer healthcare that you'd think it would make him the single-payer. Despite how confidently they talk about the subject, these people are not actually providing us with an informative economic analysis of Medicare-For-All. All they're basically doing is saying, big number, scary. Curiously absent from their cries of agony are comparisons of what Medicare-For-All would cost versus what our current system would cost. And it just so happens that precisely this comparison was provided in the very Mercatus study that they're citing. Blahous found that if you make a few assumptions about how Medicare-For-All would work, over a 10-year period, national health expenditures under Medicare-For-All would be $57.6 trillion. The $32.6 trillion figure is what it would cost on top of what's already being spent by the government on healthcare. $57.6 trillion over a 10-year period is a very large amount of money. There's no doubt about that. An even larger amount of money, however, is what we're projected to spend on healthcare under our current system. $59.7 trillion, according to the Centers for Medicare and Medicaid Services. That is to say, according to these numbers, implementing Medicare-For-All would actually save us $2.1 trillion over a 10-year period. So whenever people point to the eye-popping numbers from the study as proof that Medicare-For-All is unaffordable, understand that what they're actually arguing is that we can't afford to spend less money. Despite the way they've been reported, the numbers in the study show that Medicare-For-All would actually save us money overall, not cost us more. Now, it turns out that if you read the full study, you'll find that things are much more complicated. That 2.1 trillion saved statistic came from an analysis that took for granted several assumptions about how Medicare-For-All would work. Assumptions that the author of the study, Charles Blahous, goes on in the paper to reject. One assumption was that drug costs would decline. As Blahous writes, quote, "This analysis credits the Medicare-For-All proposal with approximately $846 billion in additional savings over the 2022 to 2031 period from negotiating lower prices for prescription drugs. This is an aggressive assumption reflecting the intent of the bill to empower the Secretary of Health and Human Services to negotiate lower drug prices on behalf of beneficiaries and specifically to promote the use of generic medications to the greatest extent possible. There are limits to the potential effectiveness of this approach to lowering healthcare costs. Generics have prices 75 to 90% lower than those of brand name drugs, but they already make up roughly 85% of all prescription drugs sold. This analysis assumes virtually perfect success for Medicare-For-All in replacing brand name drugs with generics, both for those now on Medicare as well as for the population as a whole. Therefore, actual savings are likely to be less than assumed under these projections. It is also a matter of wide speculation whether granting negotiating power to the HHS Secretary could produce savings, end quote. So here is the key question we have before us. How much money could realistically be saved on prescription drugs under Medicare-For-All? A good starting point for this analysis, and something that I almost never see conservatives do, is to simply ask what other developed countries spend per capita on pharmaceuticals. A 2017 Commonwealth Fund analysis using OECD data compares the United States against 9 countries: Sweden, Norway, the Netherlands, Australia, the UK, France, Canada, Germany, and Switzerland. The average amount spent on pharmaceuticals in these countries per capita is $532, compared against $1,011 in the United States, which is almost twice that amount. Let's say that through drug price negotiations and perhaps other legislative approaches, the United States managed to catch up to what is simply the average amount spent per capita in other countries. That would cut our pharmaceutical spending in half. How much would this save over a 10-year period? Data from Statista.com shows that in 2016 and 2017, the US spent about $330 billion per year on pharmaceuticals. And according to CMS.gov, spending over the next decade in this area is expected to continue growing at about 5%. So from a starting point of $330 billion in 2017, if you increase that by 5% every year, you arrive at a total of $4.4 trillion spent over the next decade on pharmaceuticals in this country under our current system. If all we managed to do via Medicare-For-All was simply attain international mediocrity in this area, we'd spend about half that amount per capita, and thus save $2.2 trillion over the next decade. And that's just on prescription drugs alone. Recall that Blahous described $846 billion in drug savings as an aggressive overestimate. The fact of the matter is that simply dropping our spending to the average of other developed countries would save $2.2 trillion over 10 years. And I don't think I'm calling for anything crazy or radical here. All I'm saying is, hey, maybe we could simply be average in this area. You fucking lunatic, get out of here with your liberal fantasies of being average. It's quite possible that we could save even more than this. Given that our country has a very large population of 330 million, much larger than any other country in this comparison, this large purchasing power could likely allow us to spend even less than the average of these other countries, similar to how big companies negotiate lower prices with their suppliers when they buy things in bulk. Let's look at these numbers in a different way. Blahous describes $846 billion in drug savings as a likely overestimate. Run the numbers and you find that this really wouldn't be a very substantial decrease. Knocking $846 billion off a $4.4 trillion price tag is a saving of only 19%. To say that we're incapable of cutting drug spending by 19% when we spend almost 100% more than the average of other countries is to completely lack imagination and completely lack political will as well. If all we did was set the bar this low and cut drug spending by 19%, instead of spending $1,011 per capita, we'd spend $819 per capita, which would still be more than every other country on this list. Rather than $846 billion in drug savings being an aggressive overestimate, if anything, it's the bare fucking minimum that's attainable. This is a great example of how conservative analysis on healthcare is completely completely and utterly divorced from reality. It ignores the facts, it ignores the numbers, and it ignores the uncomfortable existence of many different countries that have already done what they claim is impossible. One thing worth considering about the preceding analysis is the possibility that we use more drugs on average in the US, and that could be part of the reason that we spend so much more than these countries. Does this play a role here? Well, part of the reason we spend so much on prescription drugs in this country is because of all the stress over the high price of prescription drugs in this country. Wait, is he serious? No, I think one of the real reasons is that so many of us in this country are addicted to getting screwed over by Big Pharma. Okay, I'm done here. In a 2014 paper titled International Comparison of Medicines Usage, researchers compared 13 different countries and ranked the United States third in medicine usage. So our higher than average medicine usage rates could indeed partly be responsible for driving up our per capita pharmaceutical spending. Still, I question how much of a role this plays, and here's why. France in this study was ranked the highest in medicine usage rates. Yet if you look at their pharmaceutical spending, you see that they spent $553 per person in 2015. This is only slightly higher than the average of all these countries, and close to half of what the US spent per capita, despite the very similar drug usage rates of the two countries. So the point is that you can use more drugs per capita, but still spend radically less based upon how your healthcare system is structured. By the way, look how low New Zealand's medicine usage rates are. I'm pretty sure they have like one aspirin bottle that the entire country shares. And in case you're still somehow questioning the idea that substantial price reductions are attainable in the US, it's worth noting that according to CBO calculations, the Veterans Health Administration and Department of Defense, quote, paid roughly half as much for brand name drugs as retail pharmacies did on average, end quote. Sweet, so after I come back from a pointless war with PTSD, at least I've got that to look forward to. The CBO explains how exactly the VA achieves these drug savings. Quote, largely because of federal price controls, VHA's pharmaceutical costs are significantly lower than those of private healthcare systems. Two caps set in legislation mean that the maximum price that VHA pays for a drug is either the best commercial price net of certain discounts and rebates, or the average price paid by pharmacies minus a large statutory discount, whichever is lower. VHA receives additional discounts if drug prices rise faster than general inflation, which they have generally done. VHA negotiates further discounts with drug makers for the drugs included on its formulary or list of preferred drugs, and in return steers its enrollees to use those drugs, end quote. So not only are substantially lower drug prices reachable internationally, but some of the very same mechanisms responsible for the lowering of these prices are operational and effective within the United States. Blahous describes $846 billion in drug savings as an overestimate of what we'd see under Medicare-For-All. I would argue that much greater savings than this are perfectly within reach, and the data seems to agree with me on this. Some of the specific policy differences responsible for higher U.S. drug prices are outlined by the Commonwealth Funds. Quote, one reason U.S. prescription drug prices are higher may be the relative lack of price control strategies. Unlike the U.S., many other countries employ centralized price negotiations, national formularies, and comparative and cost-effectiveness research for determining price ceilings. In the U.S., healthcare delivery and payment are fragmented, with numerous separate negotiations between drug manufacturers and payers, and complex arrangements for various federal and state health programs. And in general, the US allows wider latitude for monopoly pricing of brand name drugs than other countries are willing to accept, end quote. Recall from earlier Dan Crenshaw saying that Medicare-For-All bankrupts his generation. Yes, nothing sends people into bankruptcy quite like spending less money does. Watch out, this new diet and exercise program will turn you into a fat piece of shit. And funny he says that, considering that some of the very policies Medicare-For-All would enact saves his fellow veterans loads of money each year. You know what really bankrupts your generation, Dan? Letting the pharmaceutical industry jack up drug prices to hilariously high levels. This is such fucking projection here. It is our current system that generates thousands of actual medical bankruptcies each year. Under Medicare-For-All, nobody, literally nobody, is going to get slammed with $200,000 medical bills for a stay at the hospital or needed emergency surgery. Nobody's drug prices are suddenly going to get raised to $9,000 a month. When opponents of Medicare for All talk about how it'll bankrupt people, they're just using the sort of dramatic, hyperbolic language that's commonly seen in partisan politics. When supporters of Medicare for All talk about healthcare bankrupting people, they're using the term literally because it happens every single day in this country. For conservatives, the term is a cute rhetorical device to use in their tweets. For progressives, it's a description of the actual reality under our current system. Let's move on to another assumption that Blahous rejects, and that's that under Medicare for All, administrative costs would be much lower. As he writes, quote, "This analysis assumes substantial administrative cost savings generated by replacing private insurance with national single-payer insurance, specifically a reduction of 7 percentage points, from an estimated 13% to 6%, in the administrative cost of covering those now holding private insurance. Again, this is an aggressive estimate of administrative savings that is more likely to lead to Medicare for All costs being underestimated than overestimated. Current administrative cost rates for Medicare as a whole are cited as being roughly 4%, though closer to 6% for Medicare Advantage," end quote. He brings up the higher administrative costs of Medicare Advantage as if it's supposed to temper our estimate of how much we can truly save on Medicare for All. I don't see what relevance Medicare Advantage has, considering that it utilizes private insurance companies, which the Sanders plan that he's analyzing would do away with, except in a few fringe areas of healthcare. Blahous says, quote, "Holohan and his co-authors conclude that 6% is the appropriate figure for estimating proposals that build upon the entire Medicare program," end quote, with Medicare Advantage once again being included in the NHEA numbers that they cite here. I'm not saying this is by definition a silly thing to do, given that the name of the proposal is Medicare for All. A reasonable interpretation of this would simply be the expansion of this program as it exists to the whole population. Realistically, though, the Bernie Sanders proposal doesn't just universalize Medicare. It does so while also making modifications and improvements to the program. And Blahous makes clear that it is this version of Medicare for All that he's analyzing. So why would we use the administrative cost of a version of Medicare for All that includes private insurance companies when the version of Medicare for All that we're advocating for and analyzing here doesn't include these private insurance companies? I see only one reason for doing this, and that's to downplay the administrative savings of Medicare for All. Another one of Blahous's reference in this section, a paper by Kip Sullivan, compares two measurements of Medicare's overhead costs, the Medicare Trustees Report and the NHEA figures. The Trustees Report found that in recent years, Medicare only spent about 1.5 to 2% on administrative costs, versus the 3 to 6% arrived at by the NHEA. Which number should we use in our analysis? Sullivan explains, quote, "The Trustees measure is the appropriate one to use in determining the overhead of the traditional Medicare program. The NHEA measure would not be appropriate because it mixes the overheads of the traditional Medicare program with the overhead of the insurance companies that participate in Medicare Parts C and D. The Trustees measure is the appropriate one to use in analyzing whether a Medicare for All system would have lower overhead than a system that relies on health insurance companies," end quote. So Blahous uses the 6% figure and thinks he's being generous, but realistically the 2% number is the better one, and this coming from one of his cited references. I don't know about you, but whenever I'm trying to convince people of something, I like to start by misreading my own sources. What kind of savings could we achieve if we spent even less on administration? The Center for Health and Economy used administrative costs of 4% in their analysis and found that over a 10-year period, Medicare for All would save $3.5 trillion in administration alone. Blahous also points out the following, quote, "One reason Medicare's administrative cost rate appears to be so much lower than private insurance rates is that they are expressed as percentages of Medicare's overall per capita costs, which are much higher. These higher Medicare costs exist primarily because Medicare serves an older population that consumes more healthcare services than the generally younger population now served by private insurance," end quote. That's a fair point, and it's definitely something that would confound the analysis. There's one thing that Blahous is forgetting, however, and that's that most of these old people would be quickly killed off in Bernie's hard labor gulag camps. So problem solved, comrade. No, I'm going to try my best to run the numbers and account for this. Using data from the Medical Expenditure Panel Survey, the Peterson-Kaiser Health System Tracker breaks down the healthcare spending by share of population. In most cases, people become eligible for Medicare at age 65 or above. The 65-plus age group is 16% of the population, yet accounts for 36% of healthcare spending. Everyone younger than this, 84% of the population, is responsible for 64% of healthcare spending. Convert these to spending versus population ratios, and you get 2.25 for 65+, and 0.76 for everybody else. That is to say, the 65-plus age group spends 3 times more per person on healthcare. Fucking old people, dude. Always gotta ruin the fun. Get off my lawn. Turn down that music. Help, I'm having a heart attack. I'm like, shut up, Grandpa. You're such a drag sometimes. Let's use the Medicare Trustees Report number of 2% overhead. That's for our current Medicare system that mostly serves people that are 65 plus. If the per-person medical spending of everybody else in the population is 1/3 that amount, it follows that per-person administrative costs would be 3 times higher, at 6% for this age group. 84% of the population at 6% overhead versus 16% of the population at 2% overhead yields an overall overhead rate of 5.36% for the entire population under Medicare-For-All. And that's assuming a fixed per-person administrative cost that wouldn't scale up or down with the amount of healthcare received. If it did scale in this way, since 84% of the population would be utilizing fewer healthcare resources, their per-person administrative cost would actually be lower than 6%, driving the overall overhead rate down even lower than 5.36. So even after accounting for this age disparity that Blahous rightly draws attention to, you find that the administrative spending of Medicare-For-All would still be even lower than the 6% that he thinks is far too generous an assumption. Once again, we see that what he describes as an overly aggressive assumption actually doesn't go far enough. Also instructive is to once again compare our spending in this area against that of other developed countries. The Peter G. Peterson Foundation compares the United States against 11 other countries and finds that we spend $843 per capita on healthcare administration versus the average of $175 in other countries. That is to say, we spend almost 5 times more in this area than they do. The Center for American Progress, using OECD data, found that administration in the US makes up 8.3% of total healthcare spending, compared against 14 other countries that range from 5.7% at the highest to 0.6% at the lowest. The average percent spent on administration in these 14 countries is 2.9%. If they can do it, why can't we? I can't for the life of me figure out why our glaring outlier status on healthcare is so often framed by conservatives as inevitable. Why is simply catching up to the average of other countries so often mocked as a hilarious pipe dream, a ridiculous left-wing fantasy that has no relation to the serious, pragmatic analysis of the conservative? There is absolutely nothing crazy about saying, let's do what all these other countries are doing. The only thing that would be insane would be to continue on our current trajectory. Also recalled that the Center for Health and Economy found that we could save $3.5 trillion in 10 years if we dropped our administrative spending to 4%. If we caught up to this average of 3%, or perhaps managed to push it even lower, we could save far more than this $3.5 trillion. You can dance around and make excuses all night long, but the simple fact of the matter is that a 3% spending rate on administration is the norm in developed countries. The 6% number that Blahous rejects is perfectly fucking doable, and we could in fact do even better than that. So not only is this assumption about administrative savings valid, but once again, Blahous actually downplays the reality of how much could be saved by Medicare-For-All in this area. Blahous also dismisses the idea that our healthcare system could function if we dropped payments down to the Medicare rates. As he writes, quote, "Under current law, Medicare reimburses healthcare providers at much lower rates than private health insurance does. In 2014, Medicare hospital payment rates were 62% of private insurance payment rates. It is not precisely predictable how hospitals, physicians, and other healthcare providers would respond to a dramatic reduction in their reimbursements under Medicare-For-All. The CMS Office of the Actuary has projected projected that even upholding current law reimbursement rates for treating Medicare beneficiaries alone would cause nearly half of all hospitals to have negative total facility margins by 2040, end quote. This is another area where I see tons of confusion. One mistake a lot of people make is thinking or implying that since Medicare payment rates are about 60% of private insurance rates, this would translate into a 40% revenue shortfall for hospitals. Blahous himself doesn't make this mistake, but we see an example of this in a Washington Post article. Quote, "When you're talking about a 40% cut, you're talking well below the cost of doing business," says Dean Waldman, a single-payer opponent. "The money has got to come from somewhere, and if it doesn't, the public will simply not have doctors," end quotes. Here's the thing that people are missing. Healthcare providers are currently reimbursed from a mixture of different sources, including private insurance, Medicaid, and Medicare. Using data from the American Hospital Association's 2016 Trend Watch, we see that hospitals are reimbursed for about 90% of their costs by Medicare, about 90% by Medicaid, and about 140% by private payers and insurance. Since their revenue comes from a blend of these three sources, it's not like you're dropping their revenue from that 140% level down to that 90% level. Your starting point would be something approximating an average of these three numbers, 107%. That's not a perfect calculation because all I did was average the three, but if you look at aggregate hospital margins over the past few years, you find that they've been about 8%, meaning they're taking in 8% more than their operating costs. So really the correct way to run these numbers would be to say, okay, the average reimbursement rate is currently about 108% of operating costs, and switching everything to the Medicare rate would drop it to 90% of operating costs, a more modest drop of 18 percentage points, or a 17% revenue cut. A 17% drop in revenue isn't nothing, but it's not a 40% drop. There's no need to lie or exaggerate here. Let's talk honestly about the way things would be. Now, you might correctly say, hang on a sec, if Medicare pays at 90% of operating costs, doesn't that mean Medicare-For-All would short hospitals by 10%? As Dean Waldman says, the money has got to come from somewhere. Yes, if only hospitals could cut costs in some area, like, I don't know, administration. Cut administrative costs in half, which is perfectly doable under Medicare-For-All, and that alone covers most of the 17% pay cut. A 2014 health affairs paper by Himmelstein et al. Found that in the US, 25% of hospital costs go to administration. Cut that in half under Medicare-For-All, which would bring us right to the level of Canada or Scotland, and 12% of that pay cut is accounted for. Where would the other 5% come from? I can think of countless sources. Maybe we can push our administrative costs that much further down. Maybe driving down the cost of medication would cover this. Maybe there'd be 5% less to spend on medical equipment. Maybe we would have to do the unthinkable and cut the pay of healthcare employees by 5%. That would mean that instead of making $230,000 per year, the average specialist in the US would have to somehow survive off of $218,000 per year. Jesus Christ, only $218K per year? You'd have to start driving for Uber or something. Vomit in the back of my car and I'll take good care of you. Ugh, he's like, fuck, I was just joking about that. Get out of here, dude. Many conservatives are quick to express their indignation at the suggestion of pay cuts. We read the following in a Heritage Foundation publication entitled, "How Medicare-For-All Bills Would Worsen the Doctor Shortage." Quote, "Medicine is a tough and often stressful profession, and medical students routinely incur large personal debts. In 2018, according to the American Association of Medical Colleges, the median medical school debt amounted to $195,000, end quotes. This apparently is supposed to serve as the justification for keeping doctor pay high, but there's a very obvious problem with it. Almost everybody who's calling for Medicare-For-All is also calling for tuition-free college, if not the elimination of student debt as well. So if they didn't have these massive chunks of student debt to contend with, then I'm sure a modest 5% pay cut wouldn't be the end of the fucking world for them. Compare our physician compensation with the rest of the world, and you see that our doctors are very highly compensated. Our general practitioners make more than any other country, pulling in an average of $161,000 per year. And only 2 countries surpass our average specialist compensation. The Netherlands at $253,000 and Australia at $247,000. Let's be clear here, I'm perfectly happy with doctors and other medical professionals being very well compensated. It's difficult, important work that takes years of study and training to master. I don't think that doctors and nurses should be dressed in filthy rags and thanklessly working for crumbs in the dirt. But let's let's keep things in perspective here, even if we had to go the route of outright pay cuts, which is one of many potential options for cutting costs. Earning $153,000 per year instead of $161,000 per year isn't the end of the fucking world. And if it meant comprehensive care for all citizens, I'm sure most doctors would be happy to make the painful sacrifice. You might have noticed that the above calculations would have only brought us to the point of hospitals being revenue neutral. If we still did want a system where many hospitals were for-profit institutions, fine, we'd only have to cut a few additional percent out of all these potential areas. Let's also not make the mistake of saying that what hospitals are currently spending is the only or the lowest amount that they could possibly spend. These are their spending levels under our current system, where the private side of it supplies them with generous windfalls. They've adapted to operating with the current amounts that they're taking in each year, and if their revenue dropped slightly, they'd be able to adapt to that as well. It sort of reminds me of how many police departments are dependent upon revenue from civil asset forfeitures to the point that they've even built it into their budgets. They've just come to expect it as the norm. If that source of funding dried up, I'm sure they'd be able to make the necessary changes to continue operating without that revenue source. It's also not just conservatives who make these arguments. Democratic presidential candidates like Amy Klobuchar will also repeat some of the very same talking points. To her credit, however, Amy Klobuchar did recently unveil her own plan to reduce healthcare spending. She's going to stop throwing staplers at her campaign staff. Another candidate, John Delaney, said the following in a recent debate, quote, "If you go to every hospital in this country and you ask them one question, which is how would it have been for you last year if every one of your bills were paid at the Medicare rates, every single hospital administrator said they would close. And the Medicare-For-All bill requires payments to stay at current Medicare rates. So to some extent, we're supporting a bill that will have every hospital closing," end quote. After he made this point, the John Delaney supporters in the crowd exploded with applause, all two of them. Asking hospital administrators whether we should give them less money or not seems like a pretty classic case of letting the fox guard the henhouse. They're like, oh yeah, no, you should totally keep giving us more money. Notice also that Delaney is asking these hospital administrators the wrong question here. He asked them, would you be able to pay every one of your bills at the Medicare rates? He's missing the point that under Medicare-For-All, they wouldn't have to pay every one of their bills, because administrative costs would sharply decline. So he's presenting them with a completely false scenario that doesn't actually capture what would happen under Medicare-For-All. In every Medicare-For-All proposal that I've looked at features a several-year phase-in period that would give hospitals and healthcare workers time to adjust to the coming changes. It's not like we would pass the bill and then immediately pull the rug out from under them, like, oh, you're running a slight deficit this year? Guess we're gonna have to come by today and shut the place down. But wait, they're about to do heart surgery on me. Toss this piece of shit in the gutter and let's get the fuck out of here. Matt Brunig points out that there's another thing we could do to alleviate these concerns. Quote, if policymakers are worried that hospitals might close, they could neutralize this problem by authorizing the federal governments to keep closing hospitals open by buying them and operating them publicly, end quotes. If conservatives are correct that Medicare-For-All would truly be so disastrous for healthcare workers, why is it that more of them support than oppose the policy? Here's what a 2017 Merritt Hawkins survey found, quote, the survey of 1,033 physicians indicates that 42% strongly support a single-payer healthcare system, while 14% are somewhat supportive. Over one-third, 35%, strongly oppose a single-payer system, while 6% are somewhat against it. The remaining 3% neither support nor oppose single payer, end quote. So according to this data, 56% of physicians support single payer compared against 41% that oppose it. This polling data also incidentally makes a mockery of the conservative argument that single payer healthcare would turn doctors into slaves, as Rand Paul and Ben Shapiro have both argued before. Yes, haven't these physicians in the survey seen the cruel tyranny that doctors in other countries experience? Well, it's been a long, hard day of work at the hospital. Time to go home for the day. I don't think so, said the cruel government bureaucrat. You'll go home when I say you can go home. Another survey specifically zeroed in on the financial aspect of our healthcare system, asking, what do you think would be the best outcome of future payment reform? 9% said deregulated markets, 26% said widespread risk sharing and shared savings, and 49% said single-payer healthcare. Among clinicians, 55% said single-payer was the best way to reform healthcare payments, and that's out of several different options. Conservatives and centrist Democrats very often take it upon themselves to speak on behalf of healthcare workers, telling us about how terrible things would be for them under Medicare for All. But when you actually ask their opinion on the subject, you find that a majority are in support of single-payer healthcare. One of the main reasons for this support seems to be frustration with private insurance companies. As Managed Care magazine wrote in 2016, quote, "A survey published in Health Affairs looked at primary care physicians in 10 countries: Germany, the Netherlands, Norway, Australia, New Zealand, Switzerland, the UK, the US, Canada, and Sweden. The study states that while the vast majority of primary care doctors across countries are satisfied with their practice and income, the themes of frustration with administrative burden and insurance hassle resonate across many of the countries. This is particularly true among those with multi-payer private insurance systems: Germany, the Netherlands, Switzerland, and the United States," end quote. President of Physicians for a National Health Program, Dr. Carol Paris, detailed why exactly this is so frustrating for physicians. A big part of it is the sheer amount of time spent in our current system arguing with insurance companies over bills and money. Once we switch to single payer, all of that time will now be available to argue with your wife about bills and money. Quote, "Don't assume physicians prefer dealing with private insurers just because they pay more. Private insurers make their money by paying out less in claims than they collect in premiums, and make us jump through bureaucratic hoops to secure payments. Basic tests and treatments must be cleared in advance with insurers or they won't be covered. Claims are routinely denied. If you've ever spent hours on the phone haggling with your insurance company, then you've had a small taste of what it's like to practice medicine today. Since for-profit insurers ultimately decide what will be covered, it's like having a third party in the exam room second-guessing our medical decisions. This process disrupts the doctor-patient relationship. And co-pays and co-insurance, what patients pay out of pocket, mean that even smaller practices must employ several full-time staff just to handle payments, billing, and collections. Doctors personally spend 9 hours each week on billing and administration. That's time we're not seeing patients. Dealing with one single payer, Medicare, would mean drastically fewer hours of uncompensated administrative time, fewer office staff, and lower overhead. Medicare for All would simplify hospital payments by funding them through global budgets, similar to the way fire departments are paid, rather than the current patient-by-patient payments, saving billions more in administrative costs," end quote. Cutting back on healthcare administration doesn't just save us money, it improves the entire experience for both the patient and healthcare practitioner. Getting rid of this administrative burden would allow doctors to focus on what really matters, spending 35 seconds in the room with you before handing you off to the nurse assistant. So, tell me what's going on today. Well, I woke up yesterday feeling, yes, of course, I see this all the time. I'm like, what? You haven't even let me explain what's going on yet. He's like, don't need to, I'm that good. I'll go ahead and write you a script and Hannah will take it from here. I'm like, you're not even writing a prescription right now. I can see what you just wrote on your notepad. Patient looks like Eric Foreman, LOL. He's like, that's just so the pharmacist can recognize you, duh. Tell you what, let me make it up to you. Pull down your pants and I'll take a look at this rash. I'm like, what rash? I'm here because my shoulder is hurting. You're the worst doctor I've ever had. I'm out of here. I also want to point out my frustration with many of the fact-checking articles that were published about this Mercatus study. Article after article purported to fact-check the statement made by Bernie Sanders that according to this study, Medicare for All would actually save $2 trillion over 10 years. The fact-checkers were quick to point out that this was only according to assumptions made in the study that the author went on to reject. Okay, that is correct, but I don't know if I'd necessarily call that a fact-check. This is what they're basically saying here. Bernie Sanders makes these assumptions, but Charles Blahous rejects them. This has been a fact check. Has it though? This is more of a he said, she said than an actual investigation of what the facts are. Who is actually correct in their assumptions? To what degree would Medicare for All cut or increase spending in these areas? Answering those questions would be a fact check. All I saw these fact checkers doing was handing Blahous a megaphone to uncritically repeat his assertions, many of which I've found to be completely untrue here. Blahous claims that this $2 trillion figure is based upon very generous and unrealistic assumptions, but when you carefully investigate each one of these areas, you find that he understates the savings that we'd see from Medicare for All. He thinks $850 billion in drug savings is far too high. Simply matching the international average, however, would save $2.2 trillion over 10 years. He thinks dropping administrative spending down to 6% isn't actually attainable. The international average is 3%. Dropping our spending to 4% in this area would save $3.5 trillion. He thinks there's no way we could make payments at the Medicare rates, but when you actually run the numbers, you see that it's perfectly doable. Using these numbers, what conclusion do we arrive at? $5.7 trillion in increased demand, minus $5.3 trillion from Medicare payment rates, minus $2.2 trillion in drug savings, minus $3.5 trillion in administrative savings, equals $5.3 trillion saved over a 10-year period, under Medicare-For-All using perfectly reasonable assumptions. Where is that fucking fact-check article? And let's not just assume that Blahous is correct here, but let's push it even further. Let's say that under Medicare-For-All, payment rates would have to stay the same. There'd be no drug savings, and there'd also be no administrative savings whatsoever. Completely ludicrous assumptions, but let's make them. That would basically zero out all of those savings and leave us with $5.7 trillion in increased healthcare demand. Even if this was the financial reality of Medicare-For-All, more money spent is not the end of the analysis when it comes to healthcare. Yes, we'd be spending more money here, but we'd also be providing all Americans with comprehensive health coverage. 9% of Americans have no health insurance, and 29% are underinsured, and thus more likely to skip out on needed medical care because of the high cost. By one estimate, 45,000 Americans die each year due to a lack of health coverage. Paul Ryan's like, good, dying prematurely builds character, something you lazy liberals know nothing about. Even making the absurdly unrealistic assumption that Medicare-For-All would save no money in any area, all it would take to provide every single one of us with comprehensive healthcare is an additional $5.7 trillion over 10 years. That's $570 billion per year. Cut our military spending in half, and that alone gets us about 2/3 of the way there. $570 billion per year would be a small price to pay to bring so many millions of Americans into our healthcare system and literally save tens of thousands of lives each year. There is a very real human cost to our current system that gets completely overlooked in narrow discussions about how much certain proposals would or wouldn't cost. Even if you envision the absolute worst-case financial scenario that conservatives paint for us, I would argue they still end up on the losing side of this debate. So that's the Blahous Mercatus study right there. What are some of the other estimates of what Medicare-For-All would cost us? The Urban Institute found that over a 10-year period, it would cost an additional $32 trillion, on top of the projected $25 trillion that the government would spend on healthcare. That's a total of $57 trillion over 10 years, which, compared against the projected $59.7 trillion under our current system, would mean $2.7 trillion in savings. The Committee for a Responsible Federal Budget arrived at an even lower estimate of $28 trillion additional dollars over 10 years, making for a total of $53 trillion, or $6.7 trillion in savings. A Perry-UMass analysis found that Medicare-For-All would save about 10% each year, or about $6 trillion over the next decade. The only study I found which predicted a net increase in healthcare spending was a RAND analysis which found that Medicare-For-All would cost an additional $69 billion each year, or $690 billion over a 10-year period. Assuming a 5% growth rate each year, it'd be more like $870 billion over 10 years. Even if this was correct, once again, I would argue that this is a small price to pay for comprehensive universal healthcare. And of course, no healthcare spending video would be complete without comparing per capita spending in the US against that of other developed countries. According to OECD numbers, in 2016, per capita healthcare spending in the US was $9,982. The OECD average was $4,003. We spend basically 2.5 times more per capita than comparable countries do on healthcare, and that's with 10% of our population lacking health insurance. Now, of course, other factors could be partly responsible for these differences, whether we're talking about poor diet, less exercise, more smoking, and so forth. The Peterson-Kaiser Health System Tracker reports that disease burden in the US is higher than the comparable country average, 24 per 100 versus 19 per 100. Complicating things is the fact that a crappy healthcare system could arguably increase a country's disease burden. A different metric worth looking at is healthcare utilization, which by some measurements is actually lower in the US than other developed countries. As we see in a 2015 Commonwealth Fund publication, the US had an annual average of 4 physician visits per capita, compared against the OECD median of 6.5. The US also has shorter than average hospital stays than the comparable country average, 6.1 days versus the average of 10.2 days. Removing the outlier Japan from this dataset, you find that it's 6.1 days for the US versus an average of 7.7 days for the other countries. While looking at these two metrics doesn't constitute a comprehensive analysis of this question, they do indicate that higher healthcare utilization does not explain the higher per capita healthcare spending in the United States. The Commonwealth Fund concludes that, quote, higher spending in the US appeared to be largely driven by greater use of medical technology and higher healthcare prices, rather than more frequent doctor visits or hospital admissions, end quotes. With all of that said, if we manage to drop our overall healthcare spending down to the level of these other countries, cutting it in half would save $30 trillion over 10 years. Cutting it down to the OECD average would save $36 trillion. So savings in the ballpark of $5 or $6 or $7 trillion, far from being unattainable pipe dreams, should be a fucking cakewalk. There's no way Medicare-For-All could save that much money. I'm sorry, but the citizens of all these different countries are a walking refutation of that claim. If we implemented healthcare reforms that moved us closer to the systems of these other countries, it naturally follows that our spending levels would also move in their direction. In one of the recent Democratic debates, Bernie Sanders pointed out how much we spend on healthcare compared against other countries, and Joe Biden had a very interesting response.
Let us be clear, Joe. In the United States of America, we are spending twice as much per capita on healthcare as the Canadians or any other major country on earth.
This America.
Ah, yes. Thank you for reminding us what the name of our country is. You fucking nailed it, Joe. I don't think he was actually meaning to make a point here. It's just that his cognitive decline is so serious that he literally wrote on his hands, "This is America," so that he wouldn't forget during the debate. This is America! Yes, Joe, that's correct. This is America. Are you my son? No, Joe, I'm actually not your son. Here, let's get you a nice warm glass of milk before bed. How's that sound? I'm imagining a Joe Biden campaign debate watch party where they're like, yeah, this is America. Good point there, Joe. Anyway, who wants another drink? I'll take 5. Opponents of Medicare-For-All seem to think that they've found our kryptonite, the words middle class taxes. In a Daily Wire article written by Frank Camp, we read the following, quote, according to multiple estimates, the cost of Senator Bernie Sanders' Medicare-For-All system would be approximately $32 trillion over 10 years. Sanders has previously acknowledged that middle-class taxes will have to be increased for a Medicare-For-All system to function, end quotes. Yet again, we see the classic move of saying big number scary without comparing it against the even higher cost of our current system. Not only that, but Frank also talks about tax increases to fund Medicare for All without mentioning that net spending will decrease through the elimination of out-of-pocket healthcare expenses. There is no excuse for omitting this information. The way this is written dishonestly makes it seem like these tax increases will be on top of what we're already spending on healthcare, rather than a more affordable substitute for current expenditures. If you have even the faintest understanding of the subject, all of this should be absolutely clear to you, but it's nonetheless worth looking at some numbers to illustrate how exactly this would work. Recall that according to 2016 OECD numbers, per capita healthcare spending in the US was about $10,000. According to that UMass analysis, Medicare for All would drop healthcare spending by 10%, meaning we would now be spending about $9,000 per capita. Yes, almost all of this would now be paid by various taxes instead of being paid to private insurance companies, but the net amount spent per capita would decrease by $1,000 per capita on average, according to this estimates. This is the financial reality of what would actually happen under Medicare for All. All I ever see conservatives and centrist Democrats do is engage in a cheap scare tactic where they remove all context, scream about tax increases, and expect you to know so little about the subject that you fall for it. It's also funny that they think of this as a gotcha point. We're like, hey, let's fund healthcare through our tax dollars. And they're like, wait a sec, that means we're gonna fund healthcare through our tax dollars. Whoa, dude, you caught us red-handed there. We also need to keep in mind that the tax burden of Medicare for All wouldn't be equally distributed among all income levels. If spending dropped by 10% under the plan, it's not like all Americans, whether poor, middle, or upper class, will pay $9,000 in taxes for healthcare. That would just be the per capita average. The actual tax obligation would correlate with your income. So the poorest Americans would have a small tax burden, middle-class Americans would have a moderate tax burden, and the wealthiest among us would have the highest tax burden. Compare this against our current system, where if you want to get healthcare through a private insurance company, they don't charge different premiums based on your income level. Your copays and deductibles don't scale with your earnings. They say, here's what it costs, this is what you have to pay, and that's the end of the conversation. It is only through government programs like Medicaid that many of these low-income Americans even have health insurance. So whether we're talking about Medicare-For-All or whether we're talking about our current healthcare system, in both cases, taxpayer-funded government programs provide financial relief in this area for lower-income Americans, not financial stress. On top of that, Medicare-For-All wouldn't only be financed through the personal income tax like opponents frame it as. Bernie Sanders has proposed many different sources of tax revenue, including a tax on employers, increasing the estate tax, closing tax loopholes, imposing taxes on Wall Street, and so forth. So distributing the tax burden in this way would provide further financial relief for poor and middle-class Americans. Let's say you're still looking for a very specific answer to a question like, under Medicare-For-All, how much more or less will be spent on healthcare by a single man living in Nebraska who makes $53,000 per year? The answer is it depends. It depends on how much he's currently spending on healthcare, and it depends on what exact mixture of taxes are decided upon to fund the program. The key point, however, is that on average, poor and middle-class Americans will spend less on healthcare for all of the previously mentioned reasons. If there's one group that's most likely to have a higher tax obligation under Medicare-For-All, it's the very wealthiest among us who have the money to afford it. And if it means comprehensive healthcare for all Americans, I would be perfectly okay with that. So let's review the key points made here. Conservatives cite the Mercatus Center study to prove that Medicare-For-All is unaffordable, costing the government an additional $32 trillion over 10 years. That same study, however, found that it's actually $2 trillion cheaper than our current system. The assumptions used to reach these numbers, far from being unrealistically aggressive, actually underestimated the savings that we'd see from drug pricing and healthcare administration. The healthcare reimbursement rates used in the study are perfectly doable. Using more accurate numbers, I found that Medicare-For-All could save $5 trillion over 10 years in these three areas. This is similar to the UMass number of $6 trillion saved and the CRFB number of $7 trillion saved. Even if Medicare-For-All would cost more money, like the RAND analysis found, I would argue it would still be worth it to provide all Americans with comprehensive healthcare. But if other countries can provide universal healthcare while spending much less per capita, why can't we do it as well? And if a majority of US physicians support single payer, maybe it's time we actually start listening to them. Shifting our system from being privately financed to publicly financed is not the same thing as spending more money on healthcare, and pointing to the boogeyman of tax increases is nothing more than a scare tactic to distract from the very real savings that Medicare-For-All would provide. Taxes to fund Medicare-For-All would scale with your income level and would also be distributed among many different sectors of the economy. The only thing more affordable than Medicare-For-All is becoming a supporter on Patreon. Patreon.com/skepticalhuman. Go there, become a supporter today, and you'll receive instant access to all of my glorious bonus videos. If you click the bell next to the subscribe button, you'll get notified when new content is posted, and you can follow me on Twitter @skepticalhuman as well. Check out some of my other videos, share this, comment, like, blah blah blah, you know the fucking drill. Thank you all for watching and listening as always, and until next time, take care.